We'll open up the stage to questions from the audience, please. Go ahead, Kim, if you could use the mic just so our virtual speakers can hear.
Question for Dr. Ferry. That research is incredible, really, really interesting. And apologies if I missed it, but what is your timeline for completion?
From a biopsy to a drug, or doing?
For trying to expedite, like to complete your research in that attempt to expedite getting the results.
So currently, if I understand correctly, that's the challenge, is trying to get those organoids to grow in a fast enough time so we have something that we can give to the patients in a clinically relevant timeline. And so we're down to around, I can do a high throughput drug screen, my lab, I do none of this work, but lab does it in around 4 weeks from biopsy, which is not that far from, at least in the People's Republic of Quebec. It takes around that much time from the time that they're diagnosed to go through all the scans. So we do it in parallel. We do it even often before we have scans, so I don't even know what treatment they're going to get, but we do the organoids and we grow them out. So it's usually around 4 weeks we do the drug screen, which is what they've tried. The stumbling blocks are our efficiency. We're around 70%. We're able to grow them from patients. The next one is when we try to make the organ chip, we do that in parallel. As soon as we get the organoids, we start growing out the organ chip, and that organ chip takes 2 weeks. So once we have the organ chip grown, we have the information from the high throughput drug screen. So overall, it's around 5 to 6 weeks. That's with a lot of work from a lot of people in the lab. We have probably around 9 people who do this full time.
Wow. Jemika, are there questions from the audience online?
Yeah, there are. So, Denise, this is probably going to be geared towards you, but someone was just asking, they are a patient with a gastric pouch, so is their diet different than patients without a pouch?
I'm not sure if I can answer that one really well. So I don't work directly with surgeons. So I'm mainly in chemotherapy. My understanding is that there's just more capacity.
Yeah, no, it'd be the same considerations, and it's the small meals, multiple small meals, that works so well for everyone. Total gastrectomy, distal gastrectomy, pouch, no pouch, esophagectomy, Whipple. It's a very common way to manage all of these issues. It's just lots of small meals and lots of calories and lots of protein and whatever it is you feel like eating. And I think there's a lot of things that are on the internet and a lot of advice you receive from family members, very well-meaning to avoid this or that. If you want to go out and eat spicy food and it works for you, go eat spicy food.
Yeah, I agree completely. I wish we can predict who is able to do well and who is not able to do well, and I'm wrong every time. So some people do not have issues, and I've taken out the whole stomach. Other people have lots of issues and taken out half the stomach, and and pouches. Most of us in North America don't do pouches, but in Europe they're making a resurgence. I have not found any difference in half, whole, esophagus. It's hard to predict.
Laura, go ahead.
Yeah, thank you so much. This was wonderful. I had a question, if anybody had thoughts, thinking about other organs and how there's transplants that you can do. Why is stomach not one? Is it just too complicated, or do you see that in the future? Just like people can donate organs and have these transplants, why not the stomach? Just wondering.
Oh, that's a tough one. Stomach is less of an issue because the things we use to reconstruct it are actually pretty good. Where it's really tough is the esophagus, because that's where we're really limited and in our organs. And we've tried. I was early in my research career, we're doing some bioengineering with scaffold. Nothing ever worked. So that's a good point, but that we need to find another way to reconstruct these organs, but we have not been able to.
Another nutrition question. Our concern at the moment is bone density, but you might comment on that within this question. It's up to you. So with a gastrectomy, you lose your gut flora. There's been a lot of talk about gut flora and how important that is to digestion and getting your nutrition. So I'm assuming, obviously, that affects everything. So is there a way to replace that flora? And I heard somebody mention digestive enzymes. I don't know if that could be part of the answer.
So the challenging thing is we're still learning a lot about the microbiota and gut flora. And so there aren't any recommendations necessarily for probiotic supplementation in stomach cancer necessarily. So different strains have research for different conditions. We can encourage people to choose foods that are high in prebiotics, so foods that are that help to nourish your existing gut flora. So that can be really helpful. The digestive enzymes are a different issue. So sometimes, so I mentioned that you can have that exocrine pancreatic insufficiency where you're not making enough of the enzymes to digest protein or fat or carbohydrate adequately. There's a little bit of digestion that occurs just from your saliva with carbohydrates. So we tend to not see that as of a problem as much as fat. So we most often see the malabsorption of fat more clearly. So that's a separate issue. And then there's the issue where you might be making enough enzyme from your pancreas to digest and absorb nutrients, but just depending on how things have been restructured and how fast things are going through the system, as I mentioned, they might not match up. So things might be going through too fast to actually give time for the enzymes to do their magic in helping you to absorb your nutrition properly.
So I have a question. So I'm shameless, obviously. So I guess for the researchers that have been able to partner with patient advocates on your research endeavors, why is it important to involve patients in your research and in the process of research development? And what has been your experience so far, early days, working with patient advocates?
Amazing. So true. Wait, what else was I supposed to say sitting here? I think we learn. I think we learn a lot. I think we learn how to ask questions differently and ask different questions. And really, if you look at the gastro studies, we had Bilal Al-Kashaf a few years ago. If you look at what he did, looking at the outcomes in clinical trials, and the trials that surgeons set up and the trials that medical oncologists set up, they're surgical outcomes. So the question of lymph nodes and margins, and those are very important cancer questions, but the questions that the patients proposed that were important were quality of life and eating and nutrition and activities and well-being and things like that. And those are not what the surgeons have put on the trials. And so having the combination of that is really important. When we think about the chemotherapy and we think about Dr. Ferry's trials, what's really easy to measure is, how much does the tumor shrink? You can measure that because that's something you can take a little caliper and you can measure how much it shrinks. But you can't easily measure quality of life. We can't easily measure malnutrition because it's so different for each person. We can't easily measure pain because it's very different for each person. And that's what we have to look at as we're measuring outcomes. So we have to get to the point where we have the right treatments and then measure the right outcomes. So we learn a lot. And I think the advocacy here is amazing and brings so much to the table in terms of getting the granting agencies to ask the right questions and fund the right things.
Thanks for taking that hot potato first. What I like about what I think is important, we've worked with patient advocates in a prior grant as well, and when I was the only clinician and you were the only patient advocate, it was really important to make sure that the scientists are grounded and we're not too much into the weeds, and we ask questions that are important to patients. It's important for science to move to charge on, but at some point, there's a patient, there's a reason why we're doing this. And the patient advocates make sure that we are focused, laser focused on improving people's outcomes. And without looking at a protein B and breaking that down, we need to look at, we're here for a reason. And I think that's where the patient advocates keep us grounded.
Well, thank you for having us. During registration, you were asked to submit some questions, and I noticed a common theme here. And one of the common themes here is things such as HIPEC and laparoscopic intraperitoneal chemo. I just wonder, what is the landscape in Canada for HIPEC specifically? Because we get this question a lot.
Yeah.
You gonna jump on that grenade for me?
I got it. I got this one.
Sorry.
So this question is really the reason that we wanted the Trans-Canadian database, because each center is only going to be able to have 2 or 3 patients a year that this makes sense for, that this is the right treatment for the right patient. And so even if you're a high volume center like Calgary, for example, or there's centers in Quebec, if you're a high volume center doing that, the ability to come up with a large number of gastric cancer patients is very limited. And so even if you're MD Anderson, what do they have? 10 patients, 20 patients a year, very few. So that is actually, this question is one of the impetuses for the Trans-Canadian database. And so it's going to collect some of this data. Our ability to then pair this to the right chemotherapy is even harder. It is the right answer for some patients, but probably very few. We hope to expand who it's the right answer for, but I think we have to turn to the basic scientist to be able to answer what's the right type of chemotherapy and how can we expand it. It's a very big challenge, and gastric cancer is very unique amongst the rest of the cancers in terms of its peritoneal spread. So we do need options here.
I would just add that just like with Dr. Klepner's had mentioned, there could be a drug, it could work, we don't know who it's going to work in. It's the same thing with this approach. There are some patients who will benefit from it. We don't know who those are. So if we are going to do it, it has to be under a trial. So people, otherwise it's doing something, it's very controversial. Not many centers do it. We're a very high volume center. We do around 80 gastrectomies a year. This is one of the largest in North America. We don't do HIPEC because I have not seen, for this disease, the data to justify putting the patients through. Just like I wouldn't want to give a drug, which I don't know is going to work, a chemotherapy, like Dr. Klepner won't want to give a drug to a patient if you don't know if it's going to work or not. It's the same thing. I want to do that to a procedure. And I think our chemotherapy drugs for the peritoneum, just as I showed you before, and it's different when a tumor is bathed in the chemotherapy than when it's in a system normally. So we don't know how it's responding. We don't have enough data to recommend it routinely. It's going to work on someone. We don't know who they are. So if HIPEC is used, it should be on a trial. I think that's the message we need to have until we find the right drugs and the right patients.
It's a big surgery, right? I mean, you're talking about a gastrectomy is a big surgery, a total gastrectomy is a larger surgery. And when you add HIPEC to that is a very major undertaking. And I think a lot of people hold out hope to remove more and more cancer. It's hard as a surgeon to know that you can't outrun the cancer. And there are limitations to what surgeons can do. And most surgeons would not want to admit that there's limits to surgical ability, because that's not what surgeons say. But we have to recognize that there are limits to what we can do surgically. And a lot of what we do is in conjunction with chemotherapy. HIPEC is a much larger surgery, and we really need to make sure we're correctly assessing the patients and picking the right patients for it and putting them all on trial, because that's the only way we're going to move forward.
Thank you. I know that's not an easy answer. I see another question from the audience.
Hello, I'm Wendy Morton. I'm with Merck Canada, and my question is for the two patient survivors here on the panel. You both shared your experiences in your own way, but one theme was the importance of having a partner, somebody with you to help you and support you. And so my question is, any suggestion for people who don't necessarily have close enough people in their lives that they can lean on? And then how did you come into contact with My Gut Feeling? And any suggestions out there more broadly that My Gut Feeling can connect to people most in need? Thank you.
Like, I guess for me, if I didn't have Dave, definitely reaching out to My Gut Feeling was the turning point for me. There was a lack of information out there and a lack of supports. And when I came across My Gut Feeling, that's where I pulled all the information that I needed. And then on top of that was reaching out to Teresa and having someone that I could just text or talk to on the phone that could understand what I was going through. Made a huge difference.
In my case, I have no medical background at all. I didn't even take biology in high school, so this was all new to me. Luckily, I'm married to a physiotherapist who has good medical training, and one of my daughters had a life science degree, so I relied on them. I had a great GP. They're very hard to come by, and they're all overloaded, but when I was in hospital, my GP probably telephoned me every day or two, and I could run ideas by him. I had a great oncologist. I could run ideas by him. I didn't hear about My Gut Feeling until 3 months ago. I'd like to give them, I'll give them some credit, but you know.
I only met Frank 3 months ago.
Late in the cycle, but it's a great, having discovered the organization, I think, as Shannon says, it's a fantastic outreach for patients.
Thank you. So one other question, and just speaking to some of the audience members during lunchtime, one of the questions was maybe not specific to this panel, but maybe Dr. Klempner can also weigh in a little bit. Biomarker testing. So it's very hot in Canada, and obviously the larger centers, they have access through clinical trials to biomarker testing, and we're very privileged to be able to match patients to clinical trials. Frank, for example, his HER2 mutation allowed him to be a super survivor here today. So I guess whose job is it to test biomarkers? How do Canadians get access to biomarkers when, maybe they're not connected to Princess Margaret or a large cancer centers that run these trials?
I think you raise a really good point there. To get reflex testing, which means you test every single person who has a biopsy from the stomach, there are things that should be done, but it costs money to every individual hospital center, and resources. So the government has to recognize those and has to put money into them. One example is PD-L1. It was covered for a while by industry. It is no longer covered, and so you have to advocate your hospital system. It's done by, unfortunately, hospital system. So pathology departments have to be willing to put their funds into that. So PD-L1 is no longer covered in Quebec. I don't know if it is here for this disease. So we have to ask for it, and our group does a reflex now, but we're the only one in Quebec. So there are ones that are reflex now. There are HER2 and the MMR proteins. But other things are coming along, FGFR2 and Claudin 18.2. Claudin 18.2 is the next one. And that is not covered. It's not paid for. So our hospital's paying for it for our patients, but it's not. The government does not reimburse the hospital for that. And that's advocacy. We need your help in order to make sure that those things are done reflexively.
Thank you. Not an easy question for sure. And then just looking at some of the registration questions as well. So, and I'm sorry, I have like 10 pages of questions from everyone here. So I'm not going to be able to pick everyone. But another common theme that I see is, talking about psychological coping with such a difficult disease and such a difficult diagnosis. And Frank, you spoke about walking out of a palliative care unit and being essentially told that, we give up. And Shannon, your story as well, both your stories just speak about resilience. What got you through this? How did you cope? What are some strategies that our patients can learn from you?
Well, that's big. I'm not sure. I guess throughout the process, I had a great support system, to be clear. I've got an amazing family. They were, whenever I needed support, I could reach out to them. But personally, my mindset was always that I would get through this and that I could get to the other side of this. So I tried not to doubt the system. And I put all my faith in the medical professionals, and I guess that positivity maybe helped along the way. So
I'd share that. I'd say, there were 2 or 3 times when I actually doubted that I was going to get out of it. I'll be honest with you. But I sort of did a second thought and said, well, I'm paid to think in my work. So I just kept thinking. I'd say, don't stop thinking. When you're really, really sick, it's hard to think, as you know better than I. But don't stop thinking about ways out. You might prompt someone who knows a lot more about the disease than you do to say, that's not a bad thought. What about this? And, you got to believe there's a way out. And there probably is, I think, for the majority of people. It's just, it's not necessarily going to be an easy trip, but there's probably a way out.
And I also, one thing that helped me was I tried to educate myself as much as possible about what I was about to experience and tried to look into the right sources and ask the right questions. So I found getting as much knowledge as possible always helped with the nerves and, helped me get through it a little bit. So.
Another question. This one's from Mary Ellen, and it's about surgery and a little bit of nutrition. So I'm 3 years out of my total gastrectomy and having issues with fatigue and slow brain, as well as other neurologic symptoms. My GP has ordered comprehensive blood tests, including vitamins and minerals, that are usually affected through the gastrectomy, but nothing has turned up. Where do I go? Do I go to my oncologist, surgeon, dietitian? And I think that's a very good question. Is patients, Mary Ellen here is 3 years out, but even 5 years out, when patients are discharged and the long-term survivors, and they're having these complex chronic conditions related to their treatment, who do they turn to? Where do they go back to? Loaded question. Number 4.
You know my answer. So we just had a research meeting yesterday, and Katie and I were discussing who do you go to and whose responsibility is this? Who should be doing this testing and who should be doing that testing and who should be providing this? And my answer was everyone. And her comment was, if everyone's responsible, then no one's responsible. And I think both are true to some extent. It's hard to know. It's hard to know what it's related to. Is it related to the stress and it's psychological, in which case maybe the family practice doctor or a psychosocial oncologist or a psychiatrist based at the cancer center would be better? Is it still chemo brain? In which case you should be going to see the medical oncologist. Is it something about how you're eating, in which case it should be a dietitian? Or is it something functional, in which case it should be the surgeon? And so I think asking the question of everybody is probably the best thing to do, and just because everyone's answer is going to be very different. And until you start asking that question, you're not going to know. I think within the cancer system, what really strikes me coming to these meetings is the lack of knowledge of how the cancer system works and the supports that are there, and how you both went through this whole journey without knowing that my gut feeling existed. And we have, every time we have someone who comes through and doesn't realize they can get back into the cancer system to see the dietitian, and doesn't realize that all the cancer centers have a psychiatrist who specializes in oncology care. And most family doctors can support that. And I think many of us don't want to bother the teams and don't want to understand the system is stressed, especially over the past few years of the pandemic. But the resources are there, but somehow as a system, we're not doing a great job getting that knowledge out. Teresa is raising her hand. How do we do better to get that knowledge out? Because the resources do exist at the cancer centers.
So, we know that they exist, and we do try to relate that to patients. However, one of the things that I think comes up often, which is, going back to the question that was asked. So once you're 3-4 years out, 5 years out, we term it as you get fired from the oncology team. And so with gastric cancer, what ends up happening is general family practitioners don't know, I won't say, but they don't know a lot about gastric cancer. And so to get yourself back into seeing a good dietitian that understands it, or seeing a psychiatrist, unless you already have one, that gets what comes with going through everything that you've been through with gastric cancer, or the surgery, the long-term side effects, to get back into that system takes time, right? And so that's why long-term survivors often feel like they're the forgotten, sort of like, okay, well, we just got to get on with it because it's like 5 years out. But as we all know, like, you have lifelong side effects from this disease if you're lucky enough to survive it. And they do have to be addressed because it is part of the population. Like, I'm one of them. Katie's one of them. There's a few people here that I know beyond the 5 years even. And it hasn't really been addressed, I think.
So you're saying we need more guidelines to general practitioners, specialists, more research, more patient advocate input, and also partnership with the healthcare team, getting healthcare providers to know about My Gut Feeling and the resources available there. Is that a good summary? Perfect. And I think we're gonna wrap up with that. That's it for the questions. Thank you so much to our panelists, and we'll just wrap up now with our last presentation.